everybody, welcome to Mille Health Systems Virtual Town Hall. Some housekeeping notes here. If you would like to ask a question and somebody is talking, put a little note in the chat box and we will pause and take your question, and then we'll unmute you and go back. Everyone will be muted during the presentation. If at any time you're not able to hear somebody, please put a note in our chat box as well. This presentation, the recording of it, and also the slideshow will be available on our website after next Monday. We're not here tonight to tell you about how to run your business. We're here tonight to help you keep your patrons and your employees safe during COVID time. Abraham Maslow, oh, I need my clicker, sorry. So, Abraham Maslow was a psychologist who in 1943, it's not moving for me. There it is. 1943, he developed this now famous theory called the hierarchy of needs. According to Maslow, our actions are motivated by a search to achieve certain needs. Why are we referencing this tonight? Because though we see many happy people all over gathering and having fun, and we would like to gather with them, we know that a majority of the population is afraid of coronavirus and being exposed. 66% of respondents in a recent Gallup poll that was held, from May 24th to June 4th, said they're worried about contracting COVID or giving it to someone that they know or love. So as we continue to reopen, we all, and that includes all of us here, need to reassure our clients and our customers and our employees that we're doing everything we can to keep them safe. As we all know, in this small community, word travels fast, so it makes sense that a solid safety plan will translate to customers' trust and a healthy bottom line. So back to this pyramid. Safety, as you see, is number 2, right after food and shelter. So we're here tonight to give you some background, ideas, and tools to help you reassure those that you work with and serve. Incident command is a structure that was begun by FEMA after 9/11. And we at Mille Health Systems started our incident command for this disaster plan in March. Some of our command leaders are here tonight and will be presenting. So right over here to my right is Dr. Tom Bracken. Tom's the Infection Prevention Medical Director. Over here is Bill Nelson, our CEO. Kim Kucera, our COO and Incident Command Chief. Vicki M. Engemark, our Infection Preventionist. And Kim Neisted, our Employee Health and Safety Specialist. So I will turn it over to Bill, our CEO.
Thanks, Mary. Again, thanks for joining us tonight. We appreciate your time. Also, thanks to the presenters for your time here tonight to make this presentation possible. Again, we're here for our patients and also your patrons and your employees' safety. And also, I'd like to say that we're in a healthy place. We stayed open during COVID. We had to stop some services because of the governor's order. Now we're back open and we're busy. So also I'd like to announce that our building project expansion has been approved by USDA or Rural Development, and the loan closing will probably happen on July 2nd. Then after that, we'll start construction. So again, thanks to everybody's support for our building project. It's very exciting. So we're off and going. So next one, Dr. Bracken.
Hi, I'm Tom Bracken. I think everybody knows me. I think I know who Crazy Mom is. And I'm going to talk about the medical aspects of COVID-19, which I knew nothing about 8 months ago. And just a few facts about COVID-19. And briefly summarize, it's a new virus. Symptoms really vary from asymptomatic to mild to severe to deadly. It's about 10 times more deadly than influenza, and it's not over. If you look at New York, they're tapering off because they had a ton of it. We are not tapering off because we've had very little of it. I'm going to stay with that slide. Not going the right way. There we go. I want to just tell you a few things about the virus. So this virus is brand new to the human race. A year ago, virtually nobody, no human on this planet ever had it. And that means since we're not immune to it, it will spread worldwide. It will only go away if people become immune. That can happen in one of two ways. Either they can recover from the disease or they can have a vaccine. It takes about 60 to 80% of people in any one community to have the disease and recover for the disease to vanish. And that's what we call herd immunity. We are nowhere near that. We're not even 1 to 2% here, and New York is like 30 or 40%. Second point, people react to this virus in many ways. This interacts with one of the questions people had for later. Quite a few never know they had it, maybe even 30 or 40%, but they carry it. You've heard about these people, they're called asymptomatic carriers. The majority that get sick with it only have a mild to moderate case of something that kind of feels like the flu. Cough, fever, aching. About 20% of people become seriously ill and need oxygen. Some of those people die. The death rate is somewhere about 1%. Maybe even lower now that we know there's more people that have it that we never count. Maybe around a 0.25%. Older people do worse with this disease, and their mortality rate is much higher. You've heard about nursing homes where several people die. As I mentioned before, the disease is like the flu, but more deadly. Every year, we usually have about 20 to 30,000 people that die of influenza. But already, and we're nowhere near done, we've lost over 115,000 people in this illness. That's both because it's more deadlier, 10 times more deadly than flu, and because it infects more Americans. Only about 10% of Americans or less get influenza every year, and we're thinking at least half of Americans will get this illness. There's some reasons why it seems like this is better. Maybe it's better in places like New York and a couple of other states where they've already had a lot of it. This is not true in Minnesota. We've been talking about this lately because we have a little dip, especially in our ICU numbers and in our death rate. But I think this is a calm before the storm. And every computer model says this is going to get much worse, peaking in somewhere to late summer to mid-fall. So we are not opening up our businesses and our restrictions because this virus has been here and gone. We're opening up because we can only stay extremely closed up for just a brief time. If we really wanted to stop this virus, we'd handle it like a tornado, go to the basement, not let anybody in, but we can't do that. And we're doing something called the hammer and the dance. Let's see if I can get this here. Oh, yeah, there's the hammer and the dance. So the lower, or the first curve where we do nothing shows what happens. If we had done nothing in this country, we would have gone more and more cases. Our ICUs would have been completely overwhelmed. They were overwhelmed in some places as it is, and we would have had more deaths in the long run because some people that could have gotten good care would not have gotten it. And then the lower line is what we do if we do things completely right. It's called the hammer and the dance. You do the hammer, or you really hammer down on restrictions in the beginning, which is what we did in the country, and we did a very good job of this in Minnesota. And then we have to release, and people will accuse us, the governor or whatever, of being hypocritical. Things are worse, but you're releasing restrictions. That's because you can't do restrictions forever. We release them just enough that our health systems don't get overwhelmed. If we did nothing, we would have that first curve and a lot more people would die. That's right. So this is one of the predictive models, and I realize you can't see everything on it. Just suffice it to say at the left is June and at the right is December, and the middle is September, or early October. That red dot at the top of that curve is October, and this is for Minnesota. So they're estimating in the next month and a half we'll have 3,000 deaths. They're also estimating that we will be able to meet the ICU beds and ventilators that we need. That's probably more than what we usually have, but we have extra ones set up. So that's what I have, and that's.
Dr. Bracken, somebody asked a question. So like, it's
Which
just on
one?
chat, so right here determining the 50% capacity.
I can, should I want Vicki to answer that first question.
Can you read it?
Determining 50% capacity is not accurate in small establishments. We are a combined grocery and cafe. Is it reasonable to maintain 6-foot distance between tables and seated customers and to have 5 other customers in the store? Vicki, you want to respond to that?
So I think I understand the question. So the 6-foot distancing is put out there to help decrease people spreading the disease from one person to the other, because the disease spreads when we're closer together. And we'll go over how it spreads. That will make sense with the 6-foot distancing. So the thing is to be creative in our businesses on how to make our layouts so that we can accomplish that, so we're safer. There is places that is more difficult and more challenging, and you have to decide what can you do, what can you change to help keep that 6-foot distancing, and it is going to be different.
I would add to that, I think I know what institution you're talking about. I think that'd be a very reasonable way to handle this compared to what most businesses are doing. The next question is, I would like employees to self-screen at home and stay home if they have symptoms. Now that's true for anyone, and that's great advice. And I have them call MOHS hotline to request testing. We have a COVID hotline that's answered 24/7, and yes, and they will talk to you or the employee about what their symptoms are, what their exposure is, and they can request testing, and that would be coming to the clinic, to the south door, having the swab taken, and it takes a day or 2 to get results. In this situation, I don't think we would likely be doing the rapid test. It would be a test sent down to our lab in the cities that would test it.
And you need symptoms.
And the question says if they have symptoms, and for us to test people with that test, they need to have symptoms. There are a few instances where we test without symptoms, but it wouldn't be just people that request. We don't have enough tests for them to run out.
Okay, thanks, Dr. Bracken, and now Kim.
Sarah. All right, well, welcome everybody, and thank you for joining us tonight. This slide. Bill's gonna go and handle. Right, good. So, you know, when Mary was preparing the town hall, there was questions about the safety plan that we have here at Mille Health System. You know, we started our journey early. It was March 5th. Mille Health System, we are part of a Central Region Disaster Preparedness Coalition. This coalition is about 19 hospitals across central Minnesota. It runs from edge to edge. And Mille Health System has been part of this coalition since before I came here, and I've been here for 12 years. And we've done a lot of planning, emergency planning, and it truly was our foundation when we knew that this issue was coming forward with COVID. And one of the things that we did, and Mary talked about it, we have an incident command team and members within our organization that are on that team that are help mobilizing our safety plan. And we monitored the CDC and the NDH. And you know, when we first started, we met 7 days a week. That was Monday through Sunday. And sometimes after we left the room, an hour later, things were changing. was changing faster than we could stay on top of it. So it was important for us that we kept meeting. You know, we identified 8 objectives that were truly important to the organization, to our patients, to our residents, and to our staff, that safety was number 1. And as we looked at those objectives and put them into that plan, we moved through. You know, we restricted the nursing home and assisted living right away, and we restricted hard, and we bubbled up in there to keep our residents safe. And even to this day, we have not had a resident or a staff member over in those areas that have tested positive for COVID-19. Visitor restrictions, again, it was kind of different for every area. So our nursing home, we stopped visitors from coming in right away. We did allow some in our hospital. And we talked about it every day as a team. And, you know, when decisions were made, it was made by the incident command team. The things that we could do early from CDC, what we were hearing is that, you know, enhanced cleaning and disinfecting, and staff when they came into the facility, cleaning their workspace at the start of their shifts. So if everybody did that right away when they came to work, it would keep those work areas clean. Social distancing, Dr. Bracken has talked about that. Vicki will be talking about that. But just the positive effects with social distancing. And then as things came through with goggles and masks, and, you know, when they started talking about cloth face masks and how that could help. You know, we received over 4,000 cloth face masks that were made for this facility from this community. And when we first started, it was a godsend. And it was like, okay, we got enough to start giving all of our staff cloth face masks where we started. And then we'll wash them 2 or 3 times a day. But the masks just kept coming in. And it truly was a beneficial thing for us and for the community to have face masks for anybody coming into our organization. You know, we also had to pay attention to the governor's emergency order. We, you know, even though we weren't seeing a lot of cases here, in April, we had to shut down our elective surgeries, both in our surgery department and our radiology department. And even early on in this planning, we started talking about financial. So the financial recovery and things like that started right away for us too. So how are we going to work through this? What things do we need to keep in place? It's keeping records of the cost and everything that we needed as we worked through here. So financial planning is still a big part of our safety plan. I'm proud to say that, you know, when elective surgeries opened back up May 18th, again, it was the planning. How do we do this safely? There were guidelines and rules that we had to put into place to make sure that we could do it safely, not only for people coming in for surgery, but to keep our staff safe as well. And so we opened up May 18th, I believe, and we've done, you know, somewhere close to 50 elective surgeries for people in the community. We also do testing, so if someone else is having surgery at another facility, so maybe if they're going up to Brainerd or Crosby, we assist them with their COVID test so that they get that in a timely fashion prior to their surgery wherever they're going. And so we go next slide. So in all this, you know, with planning, like I said, we'd started 7 days a week. Our incident command team, we now meet 3 days a week. We have a real good foundation. We're providing safe care. Our staff is diligent. We are kind of in a maintenance mode right now. But some of the lessons that we learned is being consistent and follow the guidelines. there is a lot of information that's out there on multiple different sites. And, we chose to follow the CDC and NDH guidelines, and that's what we stick to. And if there's a question about something and we kind of waver which way we should go, we circle back and say, well, here's what CDC is saying, and here's what NDH, and that's where we're going to stay right now. Like I talked about, identify your top priorities. What is the top priority for your business, and who you're serving? You have to be prepared to make changes. Make a process, and be diligent. We put processes in place, and it's just important that you put a process in place, you have to test it. And it's amazing, you think, oh yeah, this is great, we've got this process in place, and you tested it, it didn't turn out quite the way you wanted to. And so it's that ability to circle back to say, okay, so that didn't work, what are we gonna do differently? And then we would modify it, change it, and test it again. You think you have things buttoned down, and when something slips through the cracks, you can make change, and so that we're still preparing. So if we get a surge of patients here, we want to be able to react consistently, and do it smoothly. I talked about ongoing communication. I can't stress the importance of communication. You just need to do it often. And one of the things that we've started doing, we call them huddles. And so talking with employees at the start of the day. And so even in your business, the start of the day, talk to your employees. What's important today? What are we going to do? Is there something that we have to look with a plan? Who's going to be cleaning over here? Who's going to be watching this? And kind of work through that so that you guys are ready to start the day. And then at the end of the day, at the end of the shift, we huddle again and said, what happened today? Did anybody notice anything that we could have done differently? Was there something that slipped through that concerned you that we need to focus on, or maybe take back to incident command to look at again? And it's been really effective. We get a lot of great feedback from our staff on the front lines who are out there working through this every day. It's hard enough to work a 12-hour shift, but now you're working with a mask and goggles, and at some point they're wearing protective gowns. If they're testing, they're wearing special headgear to keep them safe. And so, it's just being diligent, circling back, and talking through those things that before they happen. So, being prepared. What are you going to do if you put guidelines in place and a patron comes into your organization and says, yeah, I'm not doing that. I'm not wearing a mask. How are you going to handle that? And so you practice and you're prepared. It sometimes makes it easier to respond to those individuals. We have screening for all of our employees. We screen all our patients. We screen through door 5. We have physical therapy on that side. And when we first started screening, we did have someone come in that refused to wear a mask. And, it kind of took the employees there to step back. It's like, yeah, okay. But it was like, no, that's not okay. And we had to talk to this person and said, this is a requirement for you to come in the facility, and here's why we're doing it. And if you choose not to do that, that's fine, but then you can't come in. We were committed to the safety of everybody else in this organization, staff and other patients. And sometimes those are hard conversations. And then just always remember, even when we talk to our staffs, and we message out daily. The 3 most important initiatives that we can do out there is good hand hygiene. Soap and water is even better, but even hand sanitizer that's greater than 62% alcohol, maintaining that 6-foot social distancing, and wearing a mask. It's uncomfortable. I wear my mask when I go into the grocery store. I wear my mask when I go to a convenience store. It's, when I see people that aren't wearing masks or I get a funny look, it's like, well, I mean, that's their choice. But we all have to do our part. And like Dr. Bracken said, even as those rules loosen up, they feel that there's enough people out there because, we had all this to start with, that there's people that will continue to do that, and they'll continue to help keep that curve low. So I don't know if anybody has any questions right now for me, but thank you again.
There are 2 questions, but we'll let Vicki take those.
Yeah, so there's a couple of questions which we'll address during my part. So I'm going to talk about infection prevention. And one thing that I think is important for all of us to remember, it's not always about us, it's about protecting the people around us. So we'll start out with how does COVID-19 spread? So COVID-19 spreads very similar to influenza by droplets. When people talk, sneeze, or cough, droplets come out of the mouth, and then other people around the area inhale it. The droplets tend to land after 6 feet, and that's why that 6 foot social distancing comes into play, because after the 6 foot area, there's not many droplets with the virus in it to get anybody else ill. So another way that this spreads is by called direct contact, and that means you touched a contaminated surface. So somebody that was sick left their germs and you touch the germs and then you bring it to your face. It has to get into your face by your eyes, your nose, or your mouth. And that's why the eye protection and the masks. So on the next screen, I'm going to show a little simplified animation of how COVID spreads. So there's your sick person coughing on everybody. And so the guy at the end is 6 feet away, and you can see that the COVID germs do not get to him. But the lady in the middle is within 3 feet, and so she inhales his droplets. So now she could be infected because she's close enough to him to inhale the droplets that have the virus on it. And then this screen shows how we get it from contacting surfaces, and then we touch our face. So another thing we get a lot is people are wondering, what does exposed mean? I'm around somebody and they are positive, or I'm around somebody who's around somebody who's around somebody. So exposure is actually having direct contact with somebody who's tested positive. So the person in red is positive. The person in the orange color would be the exposed person because they were together with each other. And the people in the green who were not around the red person, but they were around the orange person, they're not considered exposed. So if the person that's in the orange suddenly gets sick, then those green people would be exposed, because that orange person becomes like the red person. So it's direct contact is not of someone of someone of someone. And the other thing is that the definition of direct contact is not walking by somebody, it's being around them for more than 10 minutes while they're infectious. So people are infectious 2 days before they get symptomatic. So that makes it tricky to stop the spread, because you could be spreading it not knowing it. And you're contagious for 10 days and 3 days fever-free. So if you're around somebody who had COVID 3 weeks ago, you wouldn't be exposed because you don't have direct contact with a positive person because they're past their infectious period. So what we do when somebody is exposed, and this gets very confusing because there's all these numbers, there's 14 and 3 and 10. So a person is infectious, that's for 10 days after they get sick. So somebody who's directly exposed to them, now it takes 14 days, up to 14 days for them to get sick. So anytime in that 14-day period, the person in orange could get sick. So this person would have to be quarantined. So the positive person is going to be quarantined until they have 10 days after their symptoms onset. And the exposed person now has to quarantine for 14 days because we don't know when they're going to get sick. But we know that they could be coming down with it, and we would need to protect all those green people. So the people that are exposed to the orange category, if they get symptoms, that's when we want to test them. We don't want to test them before they're symptomatic because they could be symptomatic the day after we test them, and that test doesn't mean anything. So the green people who are not around anybody, we don't want to test them at all. And all people, we want to monitor their symptoms at all times so that you know if you become symptomatic, then you need to call and see if you should be tested. So the question on the chat was, on the employee testing, if they're asymptomatic but they were exposed to somebody, should they be tested? Not necessarily, because we want the positive person that is to be quarantined until their symptoms have resolved, and that 10-day rule. An exposed person would stay isolated for 14 days or away from other people. We would not test them unless they became symptomatic. So,
Should I read it?
yeah.
In most recent guidance from MDH, they note required mask and face shield for restaurant workers. Is this correct?
So I don't know if it's specific face shield, but the mask would help protect from the droplet, and the eye protection is so that we don't touch our face and get any droplets in our face through our eyes. I don't know if it's specific to face shield or just eye protection in general. Kim, do you know?
You can go on the state of Minnesota website and get specific instructions for your kind of business. That's where I would send them.
Okay. And then the other question above was,
How often should doorknobs, bathrooms, etc. be disinfected?
okay, so we'll go that one in a second here. So did we answer all the exposed? Okay. All right. So here's some of the big things to look for in the symptoms. So like Dr. Bracken said, there's a variety of symptoms from people having none at all to people having very severe. The last numbers that the CDC submitted on June 2nd was 83 to 95% of the people that get positive tested for COVID had fever. And cough is the second most common symptom, around 70%. So focusing on those two will catch the majority of people with symptoms. Some people then get short of breath. That's about 30 to 40% of the people, and those are the people that generally need hospitalization and need medical care. People that have lost appetite, loss of smell, chills, and muscle pain is around under 30%. Most of those people do not need medical care. They need support with pain medicine, but not necessarily be seen and cared for. So we're really looking at for symptoms to watch. We look for that cough, fever, shortness of breath, because that's telling us they may need medical care, and then a combination of the other ones. The symptoms appear up to 14 days after exposure, but the average is actually 5 days. So here's some things that we want to look at for, and this is actually, a lot of this is just good infection control, infection prevention practice in general, but anybody staying home when they're ill. So for COVID, we want to looking at those employees and screening them for those symptoms and fever so that you know they need to stay home or see a provider if they meet criteria like shortness of breath or blue lips. And then the social distancing of 6 feet apart, again, is to help so that we're not inhaling each other's droplets. Limiting the group size is one of the things the governor has said, okay, we went to 10 people in a group, then it kind of increased a little to 20 people outside. They're slowly increasing the groups because the more you have in a group, that one person can infect many more people. When we talk about hand sanitizers, Kim mentioned you want to use alcohol hand sanitizer that's greater than 60%. If it's under that, it has a less chance of killing the virus. And then masking. So the mask that if both people are wearing a mask, it's really hard for the droplets to escape a mask and hard for someone to inhale the droplets. So that's going to be the most protective that we can do in public, is if everybody's wearing a mask. And then when you're cleaning your surfaces, using a disinfectant, and there's lots of the standard household disinfectants are very well for coronavirus. It's an easy virus to kill. One thing you want to make sure is that you clean dirty surfaces with soap and water first. So if you come and you try to disinfect a surface that had a bunch of food on it and you don't wipe the food off, the disinfectant chemical can't get to the tabletop and it would just coat the food. So you want to wipe dirty surfaces with soap and water and then disinfect. And the recommendation is disinfecting like at the beginning of your shift and at the end, but also those high touched areas several times a day. So we are going through our health system and having high touched doorknobs and bathrooms and railings twice a shift. So that's 4 times a day for what we're doing in those high touch areas. But you have to look at how many people are touching that one area. We have left a lot of doors open in our facilities, so we don't have to touch the doors to open them. So decreasing some of the areas that are considered high touch, so they don't need to be touched. You know? Okay. And now for Kim.
I'm going to talk a little bit about having an employee preparedness plan. The state of Minnesota has requested that all non-critical businesses develop a plan, and I'll go through some of that. First thing you want to make sure that you have in your plan is to ensure that sick workers stay home. You want to have some kind of screening process for your employees, either at the beginning of their shift. I know it was asked if they could self-screen and call in. It's really up to you how you decide to do that. But if they do have any symptoms or fever, you do need to make sure that they go home. You also may want to designate an individual to do this so staff can maintain their privacy. Another thing that may be important is to evaluate your sick leave policies and make any adjustments that you need to there. You also want to establish a process to identify any contact between infected workers and other workers who may have been exposed. You would need this for your work comp investigation as well. And then establish protocols for returning to work after you've been, an employee has been sick. As you've heard over and over again, social distancing is really important. Some things to consider in your plan is maybe staggering shifts and break times for employees. Evaluate your traffic patterns in your store. Where are there bottlenecks? Where are there crowding? And how can you reduce that? Anything you can do to increase physical space in your business is helpful. Worker hygiene. Hand hygiene is very important. Maybe consider giving hand hygiene breaks for employees to wash their hands, posting signs to remind employees how important it is. And we've heard everyone say source control face coverings, very important. And then any kind of minimal contact you can have with restroom doors. The state recommends that doors to multi-stall restrooms should be able to be open and closed without touching, and that you place trash receptacles in locations by doors to ensure that paper towels can be readily disposed of when they're operating those doors. Some things to consider with your building and cleaning is your outdoor air percentage. Consider increasing the outdoor air percentage to increase solution of contaminants and eliminate recirculation whenever possible while maintaining indoor air conditions. You may also consider consulting an HVAC specialist. Set up and establish so you can document a sanitation schedule and clean those high-touch areas frequently. Also, install barriers at check-in and payment counters. As you've seen in many businesses in the community right now, there's those plexiglass barriers installed. And then also consider using credit cards that allow the client to fully initiate the payment so clerks don't have to touch money or anything. Some of the requirements of developing this plan is that you have training for your staff. Training should meet any OSHA guidelines and requirements. And then you also must make sure this plan is accessible to your staff and is posted. And then always with anything, make sure you document any kind of training that you do. Businesses must be prepared and ready to share any different updates with workers. And here is a list of resources that you can access to get a template to write your plan, and then also a checklist to make sure that you have everything that you need included in the plan. And that is all I have, Mary.
Okay. So, oh, is there a question? Wearing masks in this area? Laura?
So I agree that's a problem. Well, the question is, wearing masks in this area is almost non-existent, except for retired healthcare workers and maybe a few older folks. I think I fit in both those categories. What can we do? When I go to the grocery store in aisle, I think there's about 40% of people that I see have masks on, and all of the staff. So that's pretty good. And there's other businesses where I don't see any masks. And I heard a rumor about a business that had some negative comments indicating they didn't want people to wear masks. So what we can do with everything is mostly science. I printed stuff in the paper. I put stuff on Facebook. I have friends that have brought up things about masks that are on Facebook, and we lead by example. And if you look at the government here in Minnesota recently, and those senators and representatives sitting in the chamber are wearing masks, that's a good example. I won't tell you who's doing bad examples. There are people doing bad examples. Our CEO wears his mask here at work and in the community. So I think whatever influence we have to spread it. The bishop of my church says we need to wear masks in church, and we all do. So that's what we can do, is lead by example and share scientific information.
Mary, I could address that from a business standpoint. So I'm Kathy Hughes, and I am the assisted living director here for Lakesong. So I live and breathe all the rules and regulations that we have here. But on the other hand, I'm a small business owner. I've been in business for 20 years in a retail operation about 40 minutes away from here. So last Saturday, I opened up for the first time since COVID had hit. I have a 4,000 square foot retail operation. Our grocery store in our local town, you do not see the people wearing masks, like Dr. Bracken said, probably about 40%. So I was very nervous about opening up, requiring masks, doing the whole 6 foot distancing. And I thought, I'm not going to have people coming in there, I'm going to be dealing with this all day long. But I put a sign outside, which was a big deal, because before they even entered, they knew that the masks were required. So I didn't have to address it as much when they're walking in, because I had a sidewalk sign out that said, customers welcome, masks required. And the majority, I would say 80%, were very receptive of the fact that we were requiring masks for their safety. Did I have to educate a few as to why? Yeah, I did. Did I lose a few customers? Yeah, I did. But in the long run, I had one of the best days I'd had, because people were so appreciative and wanted to support that local business that was opening up, that they probably bought more than what they should have. But the key is put it out in front. Put it on your doors. Put it where they know what your regulations are, so that you're not having them step in and then have to deal with it. I did have a box of masks that I had obtained, had a few handmade masks, so if somebody said, oh, I really want to come in and I don't have a mask, I had something to give them. And they appreciated that too. But it is about putting it out forward and then educating as they come in as to why, even though they may think it's a falsehood of what this whole thing is.
Thanks, Kathy. So we have some questions that were submitted prior to this evening by a couple people on this call, but also we've got about 12 people that said that they are really interested in listening to it after the fact, after Monday. So a couple of those people had questions too. The first one is, I think that Kim pretty much took care of it, but it is the preparedness plan seems very confusing. Can you help us with basic steps?
Does anyone have any other questions? I think I outlined some of the basic requirements that are the government's requesting to be in the plan.
Okay. Second question, please explain the difference between the masks that seem to have a little spout on them and other masks. Vicky's gonna take that one.
Okay, so there are masks that are cloth, that are homemade, which we all started using, and that's a very practical mask. They used it in the pandemic in 1918, so all the way 100 years ago. And it does help protect people from transmitting droplets. And then we go up to a surgical mask, which is what we use in healthcare, because it has different layers of it, so it helps us not only inhale but not exhale. So it gives better protection. And then we move up to the mask called the N95, which is everybody's heard of that on all the news. All the places are asking for more N95s. N95 is a mask that is specially fitted to individual's face. So that and it has even more filtering to get smaller particles from being able to be inhaled. So they're also available for the public to use, that they don't need to have the fit testing, but for healthcare workers and for anybody else using it, OSHA requires us to be fitted so that we're safe and protected, wearing the right size mask for us to protect those particles from being inhaled. So there is masks that are out there that are for dust. So a worker would be out working in a dust field or dusty environment, it would help them decrease what they're inhaling. And then some of those masks have that little valve on it, it's a valve, so that they can exhale. So it makes the breathing easier because they're filtering what they're inhaling, but then they can exhale. So it's not as hot and muggy. However, they're not very good for a disease because you exhale all those droplets right on through the mask. So those are great for lawn mowing or for dusting or sanding, but not good for disease. And then the other thing is that you see on the news is those suits that people wear that have the hood and a hose attached to it. Those are like an N95, but they're powered. So it has a battery and a special fan in it that makes the air flow through and outside of the mask. So it's kind of like a N95, but mechanical.
Thanks, Vicki. Okay, third question. If my staff stays 6 feet away from each other, do they still need to wear a mask? The masks are very hot and after a couple hours, and it's summer. So Vicki's gonna take that one too.
Okay, so this is a common question, and everybody, even in our hospital, has the same thing. If we're 6 feet apart, can we take our mask off? So this has been addressed on several of the calls we have with the state, the Minnesota Department of Health, and the problem is that people start 6 feet apart and then they slowly migrate, and now they're 3 feet apart or 4 feet apart. So we're not really staying the 6 feet apart. So we just exposed each other unintentionally because we naturally move around. So they are still requesting that we keep a mask on, even if it's more than 6 feet. And yes, it is hot and they are hot. And one of the recommendations that they had for us was to make sure that we get beverage breaks or hydration breaks. So taking a break every so often so that we have 5 minutes, go and get a drink, sit away from it, take the mask off, and then going back to work. So that would create a different type of work schedule because you're not having one 15-minute break, but shorter little choppy breaks. So you can go get a rehydration and take a little breather.
Okay, thanks, Vicki. Okay, next question. If I have customers come in and they aren't masked, but I am, yet I read that masks really don't protect me, just protect others from me, am I the person at risk there? Vicki's gonna take that.
Okay, so let's go back to the cloth mask. So we're wearing cloth masks for source control, meaning that it's going to help us prevent our droplets from exhaling so others can't breathe it in. And then we have the surgical masks that are the PPE that give us a protection from breathing in and out. And the reason that the cloth masks aren't considered PPE is because they're not studied. So do we know that they make a difference? Well, we do know they make a difference. We have seen many people wear cloth masks, been around positive people and not get it. So, but the CDC and the MDH can't say that these cloth masks are protective because they're all made differently. There's no standard on how they're made. There's many different formulas, recipes, whatever you want to call it, patterns, I don't sew. So they can't say that these are as protective as these surgical masks because there's no requirement that they have to be. So they are going to offer some protection, but not as much. And if you are out there and other people are not wearing a mask, you're going to be somewhat protected because you're not touching your face, you're not inhaling because you can't inhale everything, but not as protective if you're both wearing a mask.
I'd like to add something to that, and Vicki started to say. I think that the way most people get this is by touching their mouth, nose, or eyes. Think of your goggles as a mask for your eyes. And you can walk into some place totally disinfected, you just wash your hands, and then you touch an object somebody else touched, and then you touch your mouth, and you can catch the disease. So you have to be more and more conscious of when are you touching your mouth, when are you touching your eyes and your nose. And wearing masks keeps you from touching your mouth and nose. Now, you sit and play with it because you're a human being, and you're adjusting it all the time. But I'm not touching my mouth, I'm not touching my nose, and I'm not probably going to put a little germ here and then touch it later. So none of this stuff is perfect, but it's a lot better than nothing, a lot better than nothing. So I think cloth masks are very helpful.
Okay. So next one is from someone who's not on the call tonight, but is going to listen in later. She said, I won't be able to listen in until the later recording, but if you could just respond to this. I'm very nervous about enforcing some things that I believe in at my place of business, like masks. I'm afraid I'll be perceived differently if my staff wears masks. I just want to protect my customers and myself, and yet I feel this pressure here locally to just relax and ignore it. Tom's going to keep that.
Well, any of us that believe in masks have felt this. Early on, first time I went to the grocery store, oh geez, I don't want to wear a mask. And I went in there and I was one of 2 or 3 people wearing them. Maybe I did feel foolish. I said, geez, I'm the head of infection control here. I have to wear a mask. And the thought I had about this later was, you have a choice. You can wear a mask and people might think you're too careful, or you cannot wear a mask and people might think you're not careful enough. Which one would you rather have? Or another way to look at it, you can wear a mask and not know who you saved from getting ill, or you can not wear a mask and someone will get ill that you didn't know. So I think that until we get to a point where people say we don't need them, the choice is clear. I think very few people are going to be angry. Right now you can't please everybody. When the governor came up with his latest recommendations, I said, if he gets criticized from kind of the right and the left, then we know he's doing it just right. That's just what happened. So there's no path you can take that you won't take some heat from one side or another. I haven't heard very many people complaining about people wearing masks. I've heard about people not wearing masks. I'm very grateful when I go somewhere and I see and taking precautions. You know, our drugstore or our grocery store aisle, they have sanitizing stuff when you walk in. All the staff wear masks. They have plexiglass on. They have places for you to stand so you're 6 feet apart. And I think they're doing what they can. I appreciate that.
Okay, last question. Isn't it true that most of the people, oh, I'm sorry, Vicki, there's 2 questions. Please explain the time thing, if you haven't already, Vicki. How many minutes you have to be exposed to someone in order to get coronavirus, and what is more important, masks or distance?
So the Department of Health and the CDC are focusing on 10 minutes to, as far as making your risk of exposure. So casual walking by somebody is considered a lower risk. Walking past somebody in the aisle of the store would be considered lower risk. Hanging out in the aisle with them for several minutes, talking, and then pretty soon your 5 minutes turns to 10, turns to 15. Now that puts you at risk. So the 10-minute is what they're using as a definition of being exposed. And more important, mask or distancing, they're both important because you don't want to inhale someone's spit.
Thanks, Vicki. Last one for Tom. Isn't it true that most of the people being infected are older and in nursing homes? I feel like the plan is really not for us normal people.
So a couple things about that. The first statement is not quite accurate. And it should be, isn't it true that most of the people dying are older in nursing homes? That is true. This is unlike influenza. Influenza hits younger people, it kills younger people at a higher rate than this illness does. We don't know why older people have trouble with it. So the number of people being infected is the same. In fact, the kids so uncommonly get ill, we don't know that they're ill. That's why the older people, and they don't get tested. So we think everybody gets it at about the same rate. Remember, none of us are immune. Nobody, not a baby, not a 100-year-old a year ago had any immunity to this illness. So there's 2 reasons why we have to be careful even though we're not older. One is if the younger people get a lot of it, we will overwhelm our ICUs and more people will die. The second is that it still kills a lot of younger people. The chairman of the school board in Ramsey County just died. She was 31. The first person in Minnesota that got this was a person in their 30s, healthy. They were on a ventilator for a month. They made a recovery, but they almost died. They had to be in a heart-lung machine. And my in-laws are in a assisted living facility, and I'm not looking forward to them dying soon, but if their assisted living facility gets it, 30% of them will die, and I just assume they not die. So we need to stay healthy to keep all of our old people from dying, and we need to stay healthy to keep our health systems from being overwhelmed.
Okay. Well, thank you very much, everybody, for attending our WebEx, our virtual town hall. You can always listen to it later, pass it on to friends of yours, other business owners. It'll be up on our website after Monday. Thank you so much, and thanks everybody.
You know, there's one more question.
Great job.
I want to address this question.
Okay.
Please explain your regional plan for COVID. And I'm just going to talk about it because I feel like I'd be a little Vicki knows more. Because I can tell you that I was surprised and amazed what the regional plan is. Vicki's been working on this for several years, various disaster plans, and the amount of planning just astonished me. This group, which it kind of goes from us to the Dakota border, it includes St. Cloud, it includes Wilmer, it includes Brainerd, and all these hospitals are working together. We meet online regularly, and they know where every piece of protective equipment, where every ventilator, where every doctor, where every bed is, and they have plans for it. St. Cloud Hospital has a plan that if as we surge, they may be doing almost only COVID and they'll have us take the other stuff in other hospitals. So the plan is to continue to meet, and we talk to them every 2 weeks and more often. We are setting up telehealth with them. Vicki talks to the people over there and every day, and we talk to the Minnesota Department of Health almost every day. So it's very well planned out. You can only plan so much if a tornado's coming at you, but I am just very grateful, and I've told them this, how well they plan, and you see hospitals from completely different financial systems coming together to work on this without complaint. So I think we're really well set there.
And even with that, this central region, these 19 hospitals, St. Cloud is kind of the mother hospital with that. They have a 4-tiered system, and we all move through that system together. And so that communication is like, if we're in tier 2, here's where we're at. It's moved through the coalition and working together as we see things increase. St. Cloud, that main region, has done a good job at moving that out to assist all of even the smaller organizations. But we've had drills and things with this group of 19 that we've participated in. And so, we had a really good relationship going into it. And I think even a comfort with each other and a trust, I think that we have a great coalition that we can help move that through. So.
Okay, any other questions from the group? If not, we will close, and thanks so much for attending, and thanks to our presenters as well.
Thanks for having everybody else.
Thank you.